Good evening. My name is Kathy Harley, and I'm the CEO of Nurses Specialized in Wound, Ostomy, and Continence Canada. And I would like to welcome all of you to our continuing education webinar, which is being given this evening in partnership with Medline. The topic is the role of new technologies in the management of biofilm. It's through collaborations with companies like Medline that we're able to bring to you some really expert speakers who are working with these technologies and also working to improve the outcomes of patients with very complex wounds. This evening, we will ask you to put any questions in the Q&A box. It's located at the bottom of your screen, so please feel free to enter any comments or questions that you have throughout the presentation, and we will have a live question and answer section at the end of the presentation. And now I would like to introduce Shelley Mazalek, the Director of Clinical Engagement of Skin Health for Medline, and she will introduce this topic and the speakers. Thank you.
Thank you, Kathy, for that introduction. We want to thank NSWOC for their partnership and ongoing support for these educational opportunities. We also want to thank all of you who have taken the time out of your very busy day to join us for this presentation. Today, the Medline team is very excited to provide you with a webinar entitled The Role of New Technologies in the Management of Biofilm. We have two presenters, Lauren Wolfe and Dr. Mark Melin. Please note that any opinions, findings, conclusions, or recommendations expressed in this presentation are those of the presenters, not necessarily of Medline. During their presentation, we encourage you to interact with them by putting your questions, as Kathy mentioned, in the Q&A window at the bottom of your screen. Both speakers will be taking your questions at the end of their presentations. Now, let me tell you about Lauren and Dr. Melin. It was during Lauren's earlier nursing career that she developed a passion for wounds and ostomy. She then attended Emory University to complete her wound and ostomy and continence certificate in 2006. In 2020, she completed her Master's of Clinical Science in Wound Healing at Western University. She currently works at Macdonald's Prescriptions, a private wound ostomy clinic, and also at Vancouver General Hospital as a part-time certified WOCN. A highlight for Lauren was being the recipient of the CRNBC Award for Nursing Excellence in 2011. All of the case studies you will see today were done at her private clinic at Macdonald's Prescriptions. Our next speaker, Dr. Mark Melin, is the surgeon and medical director of the M Health Wound Healing Institute and an adjunct associate professor in the University of Minnesota Surgical Department. His interests and educational niches include management of lymphedema in the wounded patient, the endothelial glycocalyx, adjunctive micronutrient application to wound care, micronized purified flavonoid fractions, wound pH and biofilm management, and emerging technologies in wound products and wound technologies. He also participates in the educational activities of the Surgical Department Resident Training Program. Lauren will start us off today by presenting 4 very interesting case studies utilizing these 2 new biofilm technologies. Dr. Melin will follow, and he will share more detail about how and why these new technologies are effective. So without further ado, let's welcome Lauren.
Today's disclosures: Dr. Mark Melin is a consultant for Medline Industries Incorporated, and Lauren Wolfe is a consultant for Medline Industries Incorporated. Today's learning objectives are to describe the mechanism of action for PluroGel, a concentrated surfactant gel, and IoPlex, an antimicrobial foam. Understand when to incorporate PluroGel and IoPlex into practice. Recognize expected outcomes when using PluroGel and IoPlex in wound healing. Our first case study is a 77-year-old man from the Bahamas diagnosed with an ischemic stroke who caught his foot while wheel propelling. He experienced a traumatic injury to his forefoot. His comorbidities included diabetes type 2. His ankle brachial index were within normal limits, and his footwear was addressed by ensuring that he had shoes with a widened toe box. He also required a shoe with laces to enable him to walk due to his stroke. At this point, we started PluroGel. The wound was in the inflammatory phase of wound healing, as when looking at the wound bed, you notice a combination of granulation tissue and some fibrin. 3 days later, after the start of PluroGel, you can see that the wound bed has shown much more granulation. However, we do see some maceration to the peri-wound. This was due to the cover dressing being difficult to apply because of the base of the toes. But the wound is now moving from the inflammatory phase into the proliferative phase. 1 month later, with the continued use of PluroGel, we notice how improved the wound is. The wound has now stabilized into the proliferative phase. It is much smaller, the depths have come in, and it's 100% granulated. At this point, the daughter was absolutely thrilled and wanted to know what that miracle product was that the patient was using. Case study 2 is a 75-year-old man. He was a resident of both the USA and of Ghana and was caught in Canada due to COVID visiting his sister. He had a chronic wound that he had had for quite a long time related to venous insufficiency and hadn't sought out medical treatment. His comorbidities included obesity and a previous deep vein thrombosis. His lower limb assessment showed normal pulses. His cap refill was normal, and he had +3 edema and hemosiderin staining. Looking at the wound, you can see that it's now in the inflammatory phase with the wound bed about 50% granulation and 50% slough. His peri-wound was very dry. 6 weeks later, using moist wound healing and compression, at this time we were using 20 to 30 millimeters of light compression using AccuWrap, the wound was now showing 100% granulation. 3 weeks later, we noticed that the wound started to stall. Although the picture is a little deceiving, the patient was reporting increased pain. We noticed a bit more fibrin in the wound bed. The edges of the wound were macerated, and there was a new opening at approximately 3 o'clock. Even though it appears like the wound may be slightly smaller and doing better, from the patient's perspective, he felt that the progress of the wound was not continuing on the trajectory it had been. And so we started PluroGel to see what would happen. 7 days later, we noticed that the edges of the wound were now epithelializing. We had a granular wound bed, the maceration had resolved, and the patient reported less pain. We had also increased his compression previously to 30 to 40 of the AccuWrap. And we noticed that the wound bed is now moving from the proliferative phase, and part of it is actually already starting to be in the remodeling phase of wound healing. 2 weeks later, the wound is now 100% epithelialized, and he was fit for compression stocking, and the wound was officially completely in the remodeling phase. This patient is currently in Ghana, and a few weeks earlier, I reached out to his sister to see how he was doing, and he continues to have complete closure a year later and is, despite the heat, religiously wearing his compression stockings. Case study 3 is a 76-year-old man who sustained a traumatic injury to his left leg. He scraped it on a log while kayaking and developed a deep tissue infection. His comorbidities included a remote left ankle fracture, decreased calf muscle pump, and venous insufficiency. At this time, I did not have access to PluroGel, and he was treated with an antimicrobial moisture balance. He had multiple wounds. Wounds to the lateral aspect continued to improve. However, over time, his anterior wounds stalled, and we decided to start PluroGel, but due to a tunnel of 4 centimeters, we applied it to hydrophobia rope. At this time, his wounds were in the combination of the inflammatory and proliferative phase, depending on the wound. 3 weeks later, we saw dramatic improvement where the tunnel had come in by almost half, so 50%, and was now sitting at 2 centimeters. In my opinion, the wounds are now moving into the proliferative phase as we're seeing a lot more granulation tissue, although there is the non-visible tunnel that we're unable to assess. But the fact that it is much smaller indicated to me that it was filling in with granulation tissue. 2 weeks later, as you can see in the pictures, the wounds are looking amazing. The tunnel had now decreased to 0.5 centimeters. Of note in all of this, the patient was wearing compression. We had started him off in a light compression and slowly increased to 30 to 40 millimeters of mercury. And at this time, we were using the AccuWrap. 2 weeks after this, the wounds closed and the patient continues to have full closure, and he was fit with compression stockings. Case study 4. This is a patient who has type 2 diabetes. He also has hypertension, COPD, has had a left hip replacement, a right knee replacement, has sleep apnea, venous insufficiency, and he developed a crack on his heel. He was receiving wound care, but over the next few weeks, he was discharged to self-care and was told to paint his leg or his wound with iodine. He was not very happy with that, and therefore he sought out private medical care and found me. His ankle brachial indexes were pretty okay, with the right being 1.06 and the left. His TBIs were 0.56, the left 0.52. Some of his challenges were that he slept on his back, so he had full-on pressure on that heel. He had elevated blood sugars, an elevated BMI, and he walked with a cane. At this time, I did consider a total contact cast, but he was the driver between him and his wife, and this was his right leg, and therefore he really did not want me to put him in a total contact cast or any form of an offloading boot because it would inhibit his driving. Looking at the photo of this wound, you can see that he was wearing edema wear, size medium by the yellow stripe, and the wound is showing that it's in the inflammatory phase. 3 days later, I debrided the callus and started the first application of PluroGel. 3 days after that, it was noted that the peri-wound was macerated, and this was most likely due to the ineffectiveness of the cover dressing that I was using. The wound bed, however, appears to be much more red. And although I still feel that the wound is in the inflammatory phase because it's quite smooth, I did see a significant improvement compared to pre-use of PluroGel. I also switched him to edema wear small because when we measured him, it was noted that he was right on the cusp of the small and the medium. So the medium wasn't doing him any good, and therefore I switched him down to the small. Although it was a little difficult to apply, I felt that it would give a lot better edema management. 14 days later, they were thrilled at the progress, him and his wife. As noted in the picture, his wound bed is now 100% granulation. The wound is moving into the proliferative phase. We have a decrease in callus buildup, and we've managed to achieve a moisture balance. However, 1 week later, things didn't look so good. If you noted, the wound bed is now showing some slough, a little bit more callus buildup. And what happened is he was no longer offloading. He was up to the bathroom all night because he's taking bowel prep because he had to have a colonoscopy. And that small amount of change in 12 hours was evident in the wound bed. And the wound had now moved back to the inflammatory phase. We continued the use of PluroGel with a cover dressing at this point. 1 week later, it's noticed now that he's offloading a little that the wound bed again is improved. However, we are seeing the callus build up again. What happened is that the patient and his wife ran out of the right cover dressing. They were down in the US, and I guess it's a little bit more difficult to get dressings than they predicted, and what they'd taken with them from Canada was no longer available. He also managed to break his offloading boot getting up to the bathroom because he didn't want to ask his wife to remove it for him. He struggled due to his obesity to reach his toes. And so we had his wife make a makeshift offloading boot until we could organize something else. However, I did have some concerns about his Achilles tendon. So I did get his wife to monitor that. But the wound bed is still, it's moving between the inflammatory and the proliferative phase. And at this point, we continued with the PluroGel because it was definitely much better than previously when he was not offloading. At this time, I'm going to hand over to Dr. Melin to explain to everybody what PluroGel is and how it works.
Lauren, thank you. Those were really fabulous instructional cases on the applicability of PluroGel, really from in so many circumstances. And where we use in our wound clinic is literally from head to toe. And as I think about utilization, there's a couple of people I really want to reach out to and say thank you for helping to educate not only me, but our wound clinic and utilization of PluroGel. And George Rodeheaver comes right to mind, of course, at the University of Virginia. So George is one of the ones that put in a lot of hard work in development of PluroGel and developing this, we're going to talk about this word poloxamer. And poloxamer is really what gives PluroGel the significant component of characteristics that separates it from what we would consider to be regular hydrogels or a gel. And then, I want to thank Greg Schultz. Greg Schultz has been really instrumental in helping us to understand why concentrated surfactant gels work on biofilms. And one of the things we're going to talk about is how biofilms really impact not just chronic wounds, but even in some of those acute wounds that are less than a month old, there can be a significant bioburden that has a significant impact on non-resolution of the wound. So thank you again to Greg Schultz and his partner Daniel Gibson, who have written just some phenomenal papers along these lines. So as we get into talking about PluroGel, one of the things it's often called as a concentrated surfactant gel. And the reason it is because it's not just a simple gel like we think of, but it's got these factors in it that are highly concentrated, and think of it as a soap. Now, don't confuse it, this is not a soap. But if you think about using a very dilute soap to clean a dirty, oily pan, you really got to scrub hard, and it's really hard to get the material off. In creating this concentrated surfactant gel that's got this poloxamer, it allows the gel to actually do a lot of the work in the environment to make the debris so that it comes off the wound easier, hence decreasing inflammation, hence enhancing the propagation from inflammation to proliferation, as Lauren's slide so really appropriately demonstrated. So it loosens, it softens, and it traps necrotic tissue. This is really ideal characteristics for a gel. It promotes optimal moist wound healing. And of course, wounds that dry out do not progress to proliferation and granulation and epithelialization. So maintenance of an optimal moist healing environment is critical. And the beauty of this gel is that it actually keeps moist wound healing for not only 24 hours, we've sometimes had the opportunity where we've been able to do dressing changes every other day. Now, I think, again, ideally, you're doing these dressing changes every single day, but in those situations where maybe home care can't get out that often and you're beholden to that changing regime, you know that you can have the confidence that you're going to have that moist healing environment for that period of time. Now, we do have good data that there's disruption and inhibition of biofilm in vitro. And in this study that was by Dr. Yang and then Dr. Schultz and Gibson were both a part of this. This was a porcine model that explanted porcine skin and looked at biofilm development. And it demonstrated very well, good, again, validated data demonstrating that this disrupts and inhibits biofilm, again, one of the most significant impediments to wound closure. And because of the easy applicability, not only by a patient, but by care providers, by loved ones, family members that are involved with dressing changes, it improves utilization, adherence, and compliance because we see less discomfort. So there's again, that inherent quality where we have less pain associated with wounds. And we see this experience in over 80% of our patients. Now, one of the other really interesting things about PluroGel is this inverse thermodynamic quality. So if you take PluroGel and stick it in your refrigerator, you would expect it's going to get thicker. The inverse thermodynamic component actually says it's going to get thinner in a cold environment and it gets thicker on the body. Now, this has great utility and application because then when it gets on the body, it doesn't warm up and run off the wound like so many other gels that we have access to or have used historically. So this component is incredibly unique. Part of it's because of the proxima component, and it makes application well. So again, thickens in warm environment and doesn't have that runniness where it's going to run off the wound as you've been using it. So let's talk about, again, what a surfactant is. We're going to break this down into 3 components of the word surfactant. The definition is it's a compound that lowers the surface tension between 2 agents. So the surface obviously is the SURF component, the ACT is the acting, and then the ANT is the agent. So this is a gel, concentrated surfactant gel that works right on the surface. It's a very active topical application as an agent, and it has really great, again, great utility. So how surfactants behave is that when you have a low concentration of surfactants in a liquid, it just kind of sits on the surface and really doesn't have that active component. So this is why low concentrated gels don't work as well as a very concentrated, high concentrated surfactant gel. So think again, as we talked about before with the analogy of washing dishes. You're not going to use really dilute soap to wash a dish. You want that that prescriptive concentration to wash dishes so you get all the debris off the pots and pans. So here's your first image of what a micelle is. So what the concentrated component allows is the poloxamer. So poloxamer, think of it as a chain. Part of the chain loves water, part of the chain does not like water. So the part that likes the water is called hydrophilic, and the part that doesn't like it is called hydrophobic. So what tends to happen is when you get into a moist environment, it wants to coalesce around debris. So the hydrophilic component is going to be on the inside, the hydrophobic on the outside. And the nice component, the nice characteristic about this is it then allows you to clean the wound better. It traps the debris in the inside of these micelles. And then it doesn't, because of the lack of the surface tension, because of the hydrophobic component and the hydrophilic component, it's easier to wipe away. And again, this is what validated data is demonstrated. So again, here's this hydrophilic surface, which loves water, the hydrophobic core, which then really helps pull up that debris inside. This is that active agent component and why we get such excellent outcomes in chronic wound utilization. So the hydrophilic surface, again, it actually goes on to act as an agent to soften and loosen that necrotic debris. Now, the nice thing is this does this at a microscopic level. So of course, you're not going to stick this on a thick eschar and expect this to work early. You're still going to use pickups. You're still going to use a 10 blade or 15 blade, and you're going to sharply excise that thick eschar to get down to it. But then you can let the surfactant do the rest of the work over the course of time. This has less implications for, say, less bleeding within the clinic, less pain for the patient, and overall, really great outcomes because it can treat the entirety of the wound, including areas of undermining and depths of the wound. You can get at every aspect. Now, one important point is you don't have to fill the entirety of the wound with this, and that's a big differentiator compared to what some other agents that talk about using autolytic debridement or another mechanism of action where they really want you to fill up the entire wound. That's a lot of product. The beauty of this is you can just coat the surface or put it on a carrier like IoPlex we're going to talk about, which then holds the wound so it's in contact, but you don't have to fill up the entire wound with the product. So the matrices of the micelles are constantly expanding and collapsing. This is almost like a little scrubbing microscopic activity, again, that helps to pull away that debris. So the effect of PluroGel, and again, this is back to that study that we were talking about, Dr. Yang and then Drs. Schultz and Gibson. And again, this was a porcine model in vitro to look at, and the specific bacteria was Pseudomonas. So 10 to the 4th is considered critical colonization. So if you look at the y-axis, talks about viable bacteria. The x-axis demonstrates before wiping, after wiping. and then days 1, day 2, day 3. So you can see in here when all you're doing is wiping the wound, which is not an uncommon practice within many wound clinics, is that you're really not having a significant impact on viable bacteria. So critical colonization levels, again, being anything above 10 to the 4th, is going to speak to a high colonization rate, high persistent inflammation that doesn't result in advancement for proliferation. So now here's wiping plus PluroGel. Now the PluroGel was on the wound, obviously, in this where the Pseudomonas was, and you can see before and after wiping total bacteria. And then when you add in the PluroGel at days 1, 2, 3, now you're using the concentrated surfactant gel that has the poloxamer component. You're wiping it away, and you can see the dramatic and statistically significant reduction in viable bacteria, well below that 10 to the 4th level that results in critical colonization. So again, this is in vitro data. This demonstrates the validation of the effect of all the characteristics that we were just speaking to. Now, the other place where we found great utility during the pandemic was in telehealth. We dealt with many scald burns, people making tea, people making coffee, espressos, and that hot steam hitting their forearm. We dealt with a number of people that had soup burns from the soup spilling onto them and running down their legs. And the availability of PluroGel in a non-prescriptive form to simply get onto a website, get onto a phone number, and order it up, delivered to their house, and to begin utilizing. So there were quite a few similar types of wounds that we never had come into our clinic during the pandemic, and they healed marvelously. Again, the other significant component within scald burns is the pain component. And the PluroGel, again, greater than 80%, had a very consistent resolution of that pain component, provides the moist wound environment. And the other beautiful thing about PluroGel compared to silver sulfidine and other ones, it doesn't have that pasty component gets on the wound and then it's hard to wipe off, because that component also, in wiping off to cleanse the wound, has that discomfort component. This doesn't have any of that. Very easy to wipe off of these painful wounds. So practical advantages in summary: soothing, cooling effect. It's stable. It's the viscosity. Again, it gets inverse thermodynamics, so it gets warmer on the wound. So it's not going to irritate that very fragile skin. One of the cases we're going to show coming up is in very fragile skin. We actually put PluroGel 1 to 2 centimeters outside of where the wound is to impact dermal health. We do not see this resulting in maceration of the wound like you would do with some other gels where it's put on there and it tends to hold in that liquid, and you get peri-wound maceration, which of course slows down overall healing. Again, we've used it from head to toe. Here's Dr. Rodeheaver's favorite and infamous saying of it's safe to put in the eye, it's safe to put on any wound. And then again, this is very true. Reduced discomfort of dressing changes we've talked about, and it's protocol friendly. Not contraindicated with use of such as silver dressings, other wound cleansers such as hypochlorous acid, or other type of topical agents. So we're going to talk about this in application to a iodine-bearing foam. And again, protocol friendly, I'd say you can do it in terms of telehealth, and it's very easy to teach, and it's again with good outcomes. So what can contribute to the underlying pathophysiology of chronic wounds? One of the things that we have noticed the most significantly is lymphedema or interstitial edema or lymphatic dysfunction. They're all the same thing. When there's an overload of fluid in the tissues, it results in significant edema, which is grossly underrecognized. The problem with too much edema in the legs is it causes something at the microvascular aspect. So blood vessels that are 5 to 20 microns. And to put that in perspective, a single human hair is typically about 17 to 20 microns. So the blood vessels where all oxygen and nutrient delivery occurs is 1/3 the size of the human hair. And that represents about 80% of the body. So when you have significant interstitial edema, like is demonstrated here where I'm pushing over this patient's tibia, it causes something called rarefaction. Now that's the board answer to compromise of microvascular perfusion and oxygen and nutrient delivery. So you can imagine all those blood vessels are 1/3 the size of my hair in an environment like this are all being squeezed down. They don't function and they can't deliver oxygen and nutrients. This is part of the significant reason why these wounds do not heal despite excellence in product utilization. So recognition is critical. People that have longstanding lymphedema, say you've had a previous deep venous thrombosis, you've had primary lymphedema where you've had it for since you were in your teenage years, people that have had a malignancy and have upper extremity edema and now have a wound on their arm. All of these people, control of the edema component is critical to maximizing microvascular perfusion and nutrient delivery. And then application of the products has a significant synergistic amplifying component. So here's, in fact, I just saw this gentleman in clinic today. Primary lymphedema, you can see the buffalo hump, you can see the stemmer sign, the squaring of the second toe, chronic ulcerations, and significant lymphuria. As you sit there and watch him in clinic, that wound fills up with fluid because there is so much impact and disruption of the lymphatic flow out. He has no history of deep venous thrombosis, no congestive heart failure, no renal failure, no hepatic dysfunction. All the other things you have to think about within the differential diagnosis that systemically can result in bilateral lower extremity lymphedema, because this is unusual. Most lymphedema patients we see are unilateral. So, and they're very prone to cellulitis. You can see he's got a low-grade cellulitis right now in addition to the chronic inflammatory components. So this needs absorption. If you just put PluroGel on here only, it kind of washes off it almost floats away. So you need a carrier. And this is where we've been utilizing IoPlex as a carrier to help. Now, there's a couple advantages in using IoPlex. So I tell patients it's like we're going to put butter on toast. So we put it on the IoPlex. There's no up or down. And it's a proprietary foam that is chemically complexed with iodine that's released into the wound over the course of time. So the black foam actually turns white, which is a really nice visual indicator that there has been release of the iodine, which is impacting in the wound. It's terrific in terms of overall absorptive quality. And it's when you pull it pulls up and almost pulls off some of that slough, that micelle collection with that necrotic debris, and it outlines the wound really, really well. So this has become a really great standard of care within our wound clinic for utilization. So here's an example of somebody with a left diabetic foot ulceration. He has a heel ulceration. We're doing total contact casting. So we're actually putting PluroGel on IoPlex, and then we're using Quick, which is actually another product from Medline for hyperabsorption underneath the total contact cast. And as Lauren had pointed out before, this patient's getting a form of edema wear as well to help dermal lymphangion contractility so we can improve decreasing interstitial edema even underneath total contact cast. Here's another patient that has a lymphedema of venous etiology and a really significant painful retromedullary ulceration. Again, very painful. Now, I purposely outlined where we put the PluroGel about 1 to 2 centimeters out to impact dermal health, because peri-wound maceration significantly impacts ultimate resolution. I'm going to touch a little bit on the lymphatic ventral medial bundle. And the reason it's so important is it's important on the education point to understand that lymphatics are longitudinal in terms of exiting the body. So when you put on compression that has horizontal lines like you see on the right-hand side, that's almost like speed bumps to the dermal lymphatics. And the dermal lymphatics, if you saw them underneath a microscope, it really looks like shag carpet. They're that numerous. So having your lines of dermal microdeformation longitudinally oriented stimulates lymphangions so you can get better interstitial reduction. And here's this classic paper from 1995 where they did lymphangiograms of legs. And what this is demonstrating is not venous anatomy. This is all lymphatic anatomy that's right underneath the dermis. So unlike venous anatomy where there's big perforators between the superficial and the deep systems, there aren't those big perforators to connect deep lymphatics to superficial lymphatics. So the best way, and really the maximal way of lymphatic fluid to be carried out of the leg is along the medial aspect of the knee up to the groin and then into the retroperitoneum. So when you have injuries along the medial aspect of the leg, that tends to impact dermal lymphatics, even removal of interstitial fluid along the medial aspect, even more so than any place else. Here's a complex patient, calciphylaxis. You've all dealt with patients with calciphylaxis before, and they're painful, subcutaneous calcium development. And typically there's a renal dysfunction component, which of course complicates the interstitial edema reduction in the lower extremities and management. So this was an elderly woman that came in, of course, always check to make sure arterial flow is intact. Her ABIs were fine. She had good gross and macro arterial flow. This is all microvascular dysfunction. So again, those 5, 10, 20 micron level arteries in the peri wound that's markedly inflamed, the calcium deposits pain, and that results in the non-healing. So the nice thing about in the calciphylaxis patients was application of the PluroGel on the IoPlex, and then using the edema wear to do microdermal deformation so that we get that maximizing interstitial edema reduction, because that's what results in then maximizing the microarterial flow. And you can see from initial presentation to week 1 to week 2 to week 4, really significant improvement. And the other thing I want you to see is if you look at the initial presentation where there doesn't really look like there's a wound, look at how dramatically different the dermis appears just in 4 weeks. Again, tough case of calciphylaxis. So we started treating that area right away because we didn't want that to open up into a wound. And so prevention played a significant part in this particular patient's management. Again, putting that PluroGel out 1 to 2 centimeters around the wounds to have that impact. Now, here's again, a very significant case. This is a obese patient. He's got a fixed knee contracture on his right. He's got exposed flexor tendon, as you can see, that's at his ankle mortise. And then he's got really significant atrophic skin from years of uncontrolled lymphedema and years of uncontrolled venous insufficiency. So the original consult was last October. I ended up taking him to the operating room where we debrided away all that necrotic tendon. We debrided the entire wound, and then we got him going into hypochlorous acid to decrease wound pH. We were dealing with a combination of edema wear as well as inelastic compression to maximize lymphangion function and to maximize venous hypertension resolution, utilization of PluroGel and IoPlex. And then we added in these really important micronutrients to maximize endothelial nitric oxide production to maximize periarterial perfusion. So the B12s, the B6, the folate, vitamin D, and vitamin C. It's interesting, if you look at this patient, you would almost think he's got some degree of scurvy. Scurvy still happens in 2021. I think we have to be very aware of that for our patients and make sure they're on a maximal dose of vitamin C. And we actually use about 1,000 milligrams a day. The vitamin D, we tend to do high dose between 5 and 10,000 international units a day, assuming that there is no history of kidney stones. And we max out the folate, the B6, and the B12, again, to get that maximizing nitric oxide production. And we're very favorable on flavonoids. So the hesperidin diosmin that's available in flavonoids, the other name for it is micronized purified flavonoid fractions, or MPFF. We use this in almost every single patient that we see in our wound clinic, from diabetic wounds to venous hypertensive wounds to certainly lymphedema. The European data is robust with validated outcomes and utilization. There's at least 10 randomized controlled studies using micronized purified flavonoid fractions. I would strongly encourage you to look up this data for micronutrient utilization in wounds to enhance outcomes. So here's just kind of a collage of 6 patients where we took them at intake at the original consult, and then where they sat at anywhere between 3 and 6 months later. And I think the important thing to see is just the difference in overall dermal health and the reduction in inflammatory changes. It's interesting, a lot of those inflammatory changes also come from histamine release. Now, histamine is coming from the macrophages and other components. And if you think of histamine, say with spring allergies in your face gets a little puffy and your nose gets runny, so you get rhinorrhea. And the first thing you reach for is what? An antihistamine. So a lot of these patients also, once we confirm there's not a component of cellulitis and infection, if it's just chronic inflammation, we'll actually put a steroid on the skin. We'll wrap the leg in saran wrap for an hour. And we do that about 3 days a week to decrease that histamine release And by getting rid of the histamine, we decrease hyperpermeability in the microvasculature that complements decreasing the interstitial edema. So that's how we end up getting to this significant change in dermal health in 3 to 6 weeks. And a strong dermis helps decrease recidivism rates. So it's the complement of all these factors with a couple really core products, including PluroGel and IoPlex, that really make a significant difference for our patients. So in conclusion, we use PluroGel and IoPlex oftentimes at the initial consult. We have we have phenomenal nursing staff, and they do a great job in terms of education. And we have a terrific Medline representatives that we work with to have uninterrupted product availability. 90% of chronic wounds have a biofilm. I think you can now understand the characteristics of the poloxamer within the concentrated surfactant gel that is PluroGel, and understand why utilization of this works so well in those wounds that have a biofilm. I would also say in acute wounds, we use it quickly in a lot of acute wounds as well. Those scalding burn wounds we've talked about, and even just simple cuts and simple minor scrapes. So I'll be honest, we keep a tube of PluroGel in our kitchen at all times for things such as that. Always address the cause of the wound. So that one patient that had the big legs, the chronic lymphedema, you still have to go back at the consult, even though he might come in and it's like advertised as primary lymphedema. Assess, is there a component of right-sided heart failure, increased central venous pressures, hepatic dysfunction, liver, renal dysfunction? Is there something else going on? Is the albumin low, eating too much salt, etc.? You've got to go back and run the checklist on all these patients. Maximize nutrition and micronutrients, as we discussed. Look up the data on micronized purified flavonoid fractions. It is a significant complement in terms of overall wound healing and interstitial edema resolution. And if the wound stalls or deteriorates, you kind of got to go back and run the checklist again. Did I miss arterial disease? Did I miss venous insufficiency disease? Did I miss, is there a medication? Just to mention one medication, amlodipine and Norvasc, one of the biggest offenders of causing lower extremity edema, which stalls wounds. So always go back and look at those other systemic patients. When I look at this, when it says don't blame the dressing, I would also say don't blame the patient. I think patients and families want to heal. We talk about we don't use the word compliance, we use adherence. And I usually say shame on me if the patient didn't understand the dressings we put them on. It's because I don't think we took the right efforts and the right time in terms of doing the education. So make sure your patients are well educated on what you're instructing them on so they can fully adhere to the game plan. And then always go back and recheck the checklist if things change. It's been a pleasure being able to participate in this educational environment. Lauren, I want to thank you again for asking me to the privilege to be able to speak alongside of you, and we look forward to taking any questions. Thank you.
Okay, thank you, Dr. Melin and Lauren Wolfe. And I really love the case-based learning that you brought into this presentation. And speaking of cases, Lauren, I understand that you have a newer case that you would like to present. And so I'd like to turn this over now to Lauren Wolfe, who is with us live, and she will present another case.
Hi everyone, just waiting for the slides to come up.
Sorry, Lauren, just one more second.
That's okay. So as we wait for Troy to actually bring up the slides, I'll give you a little bit of a history. So it's a woman who is in about her 70s, and she fell off her bike and sustained a partial thickness wound. According to her, it became infected and she received IV antibiotics at an urgent care center. The wound was being treated by her family physician, and she was sent to me in the private wound care clinic. She declined a referral to home health, as I always encourage patients to be referred. On initial assessment, as you can see, it was noted that she had significant varicose veins and moderate edema. The remaining lower limb assessment was unremarkable. As you can see by the wound bed is 100% slough, and so I attempted conservative shock wound debridement. However, it was much too painful, and then as per the NSWOC best practice guidelines, I opted for an alternative form of debridement, which was autolytic, and I chose PluroGel. Due to her previous infection, I decided to use the IoPlex to manage any bacterial burden. I covered this with a silicone foam, and then because of the edema, applied edema wear to manage. As you can see, 2 days later, the wound showed significant improvement with way more granular tissue. And as noted by Dr. Melin, you can see how the IoPlex has changed to that white color when the wound utilized the iodine. Also note that I actually didn't cut the IoPlex to size. And if you recall back to Dr. Melin's slides, I seem to have lost the slides. Oh, if you can go back, yeah. If you look, you'll notice we didn't cut it. As I was saying, if you return back to Dr. Melin's slides or think back, he didn't cut it either to the size of the wound. We're just putting it on straight. If you look at the 5 days later, you now see that we have 100% granular wound bed. Troy, if you can advance. And then the wound continued to improve. 3 days later, we're seeing that we now have 100% granulation. The wound bed is much smaller. However, the wound bed was starting to dry out and the IoPlex was needing soaking off with saline. But I opted to continue because this treatment plan was working for her. 1 week later, the wound was closed. I did have to soak the IoPlex off, but as you can see, there was no damage to the new epithelialized tissue. The patient didn't report any pain when I removed that. What's really significant for me here is that total time from when she saw me to wound closure was under 3 weeks. And it just goes to show that if you manage the wound correctly with the etiology, combination of compression, right dressing, manage the biofilm, you can absolutely close these wounds. So now I'm going to move on to Kathy and Shelley, if there's any questions.
Okay. And I think Dr. Melin is here as well. There he is. And Shelley. And so I will bring forward the first question. This question is actually for Shelley. How does PluroGel compare to Intersite gel? Are the two similar?
Shelley, you're muted.
Thank you. I think I'm going to pass that over to Dr. Melin because he earlier in his presentation, he talked about the poloxamer, and that really is the biggest difference. So Dr. Melin, if you could just reinforce what you talked about in those slides about the difference between PluroGel and a hydrogel.
Sure. So when we look at hydrogels, the biggest difference is that poloxamer 188 component. So the poloxamer having the hydrophilic, hydrophobic chain that wraps around necrotic debris and helps to pull that debris away. No other hydrogel has a poloxamer in it. And that is really the biggest distinction between PluroGel as a concentrated surfactant gel, having poloxamer 188, and every other hydrogel. It is, and it's also the reason that we see such significant differences in peer-reviewed published data regarding outcomes. I think it's an excellent question, and I'm glad. I think this area can get very confusing, and poloxamer is a new word for many of you today. So it's a really insightful question. I'm glad you asked it.
Okay, thank you. And the next question is, thank you so much for fascinating information about micronutrients. I think a point to emphasize or clarify is whether or not there's pain or burning with the gel. So far, she says, I find no issues. What has your experience been? And maybe Lauren, you would like to start with this response.
That's an interesting question, and it seems to be quite very well. Dr. Melin and I have had a few conversations about this. I have had, to be full disclosure, one patient complain of some burning, but it does resolve after time, whereas I believe Dr. Melin hasn't had any challenges with pain. And in fact, they actually, after a while, say it feels better. So it's an initial stinging, but I think I'm the only one in people who have used it who have ever had that experience.
Okay, any other comments from you, Dr. Melin?
I would say 60 to 70% of our patients find that there is actually some pain relief degree. It's been a very, very rare patient that has not been able to complete a trial of PluroGel because of a stinging reaction or some other component. The vast majority find it to be of no discomfort at all.
Okay, thank you. The next question is, how do you recommend that I use PluroGel to a pressure injury with undermining? Do you add PluroGel to the packing ribbon? Maybe Lauren, again, if you could start.
So I think both of us have demonstrated that very often we do apply PluroGel to another product, whether it be IoPlex, say a hydrophilic blue, or another ribbon. We know that PluroGel can be utilized with any of the other antimicrobials, so choosing the right form and function of the dressing. The nice thing with the IoPlex is that it conforms and can easily be tucked into undermining. So, you know, at this time, I have IoPlex in my private practice, not in a hospital environment. Therefore, I would use a different product in a hospital. But if I had it, because of its conformability, it's a really nice product to use. I really enjoyed using it.
Okay. And any of the other panel members, do you have any comments on that?
As a surgeon, whenever I hear the word undermining, I'm always very interested in the quality and what the tissue like underneath that is, because it's another place where it's very difficult to eradicate biofilm. And you always have to make sure, especially if it's an issue tuberosity, a coccyx, make sure there's not underlying osteomyelitis that could certainly be a contributor to non-healing. So we also tend to aggressively irrigate out areas of undermining with hypochlorous acid. You could also use a dilute acetic acid, and that flushing is another way to help remove biofilm in addition to putting in PluroGel, because PluroGel again will conform very nicely to all the interstices of the undermining, and certainly putting it on IoPlex or a form of a tape will be, just make sure that you always get everything out of there in foreign bodies you put in undermining that you place.
Okay, thank you. And Shelley, do you have any other comment?
I was just going to mention that IoPlex is now available in a small size. So it's 2.5 by 2.5, a 10.5 by 12, as well as a 15 by 15, and those are centimeters. So you can cut this dressing as well. It does come in a tinfoil package, which is really meant just to keep the moisture of that dressing. However, if it does end up drying out, you can add moisture, and so you should, so that you can remove it quite easily from the wound.
Okay, thank you. The next question, thank you for your program. The gentleman with the LE wound that you used IoPlex and the gel, foam is to absorb the drainage and the gel contributes to moisture. So theoretically, these dressings are counteracting. Please elaborate. Also, is there a US company that has a foam with a surfactant?
I'm not sure if that was my case study or one of Dr. Melin's. The way I see it, and Dr. Melin, you can tell me if I'm right here, is that the PluroGel is the surfactant. It's managing the biofilm, and then the IoPlex is allowing the iodine to then be delivered into the wound. So that's sort of my take on using these products together. So yes, it does appear that they're counterintuitive because one's a gel, but this is not a typical gel. This is a surfactant. It's doing something different than a hydrogel. It's removing the biofilm by the surfactant effect. Dr. Melin, did you want to add to that?
I would add that PluroGel in inherent characteristics has no antimicrobial properties. So it can help decrease critical colonization, but it actually you can't consider it as an antibiotic. The iodine component within IoPlex certainly has some bacterial impact. So the combination together has been very fruitful for us. And it's interesting on IoPlex because as the iodine leaves the foam, it turns white and actually starts to become hard. So we see them as very synergistic components together rather than competing components. But again, I think it's a really insightful question and well thought out and well phrased. And I'm really glad you asked it because it helps bring out those characteristics, how they fit together, which you're right, intuitively it doesn't make sense. And but again, understanding the independent characteristics that work together helps understand the combination.
Okay, thank you. Have you ever used the IoPlex under a flange, an ostomy flange?
So I'm assuming that's for me as an ostomy nurse.
Yes.
At this time, I have not, but I have not recently had anyone with wounds that would be significant enough. Actually, come to think of it, I have. I've used it on one patient a number of months ago that had an abscess. So because it can be cut and be put into the tunnel, it worked quite well. But you do, you know, like any ostomy, you have to manage everything, the pressure, etc., that's causing the problems. I haven't used it a lot. I haven't had a lot of patients that have significant wounds, but it definitely should work very similar to our other products that we use under flanges. I have not used PluroGel though in combination with it.
Okay. And Shelley, do you have any other comments on that, using it under a flange?
No, I don't. I mean, there's no reason why you can't, as long as, you know, it's obviously kept moist and, you know, under a flange, it would be. So I don't see why it would be contraindicated.
Okay. And the next question is, I have not heard of PluroGel, but I'm very impressed with this presentation. I am familiar with Prontazan gel, which also has a surfactant component. Are there other differences between these two products? So Shelley, I don't know if you want to start here and then we can move out.
Yeah, I think they are quite different, but I honestly am not that familiar with Prontazan. So I'm hoping that Dr. Melin has had some experience. Maybe Lauren has too.
Again, really insightful question. That we've used Prontazan as a liquid, again, for the surfactant qualities. I have not used Prontazan gel. And again, the reason I haven't used Prontazan gel is because I'm specifically looking for the gel that has the poloxamer in it. And that again is the big separator between every other gel, is having the poloxamer as a surfactant versus other different types of surfactants that don't have the same inherent characteristics. So that's why we choose PluroGel as compared to the Prontazan gel, because it's a different type of surfactant action, which I think, and I can't pull up a peer-reviewed study, and I don't know if they've gone head-to-head. I just know where we've seen with the outcomes with PluroGel.
Great. Do you have anything else to add, Lauren?
No, I have not used Prontazan gel either. So
okay. And how about PluroGel with pyoderma gangrenosum? And maybe Dr. Melin, if you'd like to start.
Yes, we've used PluroGel among other products with cases of pyoderma. So of course, these are ones that you don't want to overly aggressively debride because you don't want to end up with pathogy. And a lot of these patients have some degree of pain component, especially if there's a secondary infection considered or as an aspect of it. So as a concentrated surfactant gel in a very difficult wound environment where you're typically having dermatology and other specialties involved, this is I think a really good choice for utilization.
Okay, thank you. How does your iodine differ from Cadaxamer iodine? Shelley, maybe we start with you.
They're similar in that they're both slow release iodine, but this one is an iodophore. Obviously, in a foam dressing, the cadexmer iodine obviously comes in different formats, not a foam dressing. So I think they all have their places, and obviously just as effective, I would say, as the cadexmer iodine.
Okay, so that's good. And I see another question here. It's around elaborating about the IoPlex turning white. And I think it was Dr. Melin that talked about that. Can you elaborate a little bit more?
And the IoPlex turning from black to white is simply the iodine leaching out of the dressing.
Okay. So
I could also mention too that if you want a longer dressing wear time, in other words, if you've got a wound such as a venous leg ulcer that is draining, you can actually stack them so that you will get a longer wear time. And the white color is a good indicator that that iodine is being released.
Yeah. And Lauren, is a daily dressing change required, or can it stay in place for multiple days?
So for me, I definitely have done multiple days, but I look at the wound assessment. So if I have a lot of drainage, then I will change it more frequently. But if I've managed to get the edema under control and the drainage under control, if it's a lower limb wound, then I'm going to extend the wear time. So I'm really going to look at my wound assessment and then discuss with the patient, because this was an outpatient clinic, the frequency of change. I believe PluroGel can be on for up to 3 days, Shelley.
That's correct.
And the IoPlex as well, you're looking to see how much of that iodine has been used up in order to know whether you need to replace it. So in my practice, the big thing is just look at the wound and see what it's telling you.
Okay, and we have time for one more question. And the question is PluroGel an antimicrobial gel?
Shelley, Dr. Melin, I'll let you take that one.
It is not an antimicrobial, but it certainly can be used with an antimicrobial. I think as Dr. Melin has shown as well, he's used it for with various different things, including, if there was time, I was going to ask you about the flavonoid that you mentioned. I had to practice all those words, and I was wondering what they actually meant. So if you could explain that, that would be great.
So just really briefly, micronized is, it takes and makes the particles very small for bioabsorption in the intestine. Otherwise, the particles are too big. They come actually from the rinds of oranges, is where the active component is. So one pill is like taking 20 orange rinds. But the medicinal part results in decreased inflammatory markers. So like ICAM, BCAM, TGF-beta. And so decreasing those inflammatory markers then decrease the hyperpermeability of the microvasculature. So you don't have as much swelling. It's really a way to decrease swelling around wounds and in legs, improving lymphatic tone, venous tone. So the micronized is a small. The purified is, it's a highly obviously purified medicinal component. And then the flavonoid, there's about 5,000 to 6,000 different flavonoids in the plant world. And many of them have medicinal properties. This is where a lot of our medicines come from. So, and then fraction is that it's using specific parts. So the one that's really beneficial is something called diosmin hesperidin. And those are two, so diosmin, eventually they're interrelated, but that's the names of the specific flavonoids that have these specific medicinal properties. And in Canada, you might know it as the word Daphlon. In fact, I was just, before I came up to this conference, I was downstairs with one of the world's international experts in flavonoids, Monica Glovitsky, who worked on a lot of the randomized controlled trials over in Europe that had set the standard for this type of medication. So there's a rich peer-reviewed published literature regarding utilization of this. And a lot of it's just understanding it because it's relatively new to the United States.
Okay, thank you. And so we are 8:05, and it's time to wrap things up. If I could just get each one of the panel members just to make a last comment of something that you would like as a takeaway in relation to the presentations from tonight. So maybe Lauren, we'll start with you.
I'm going to do a general comment, which includes it's just really look at your wound assessment, and look at your etiology and choose the right product for the wound at that time.
Okay, thank you. And Dr. Melin.
Well, first, I would tell you, Kathy, you've been a great moderator, so thank you for taking the time tonight with us. And Shelley, thank you for all of your expertise. And Lauren, it's always a pleasure to present with you, and hopefully we can present together. In the assessment of wounds, it's focus not just on the wound, but look at the systemic health. And if you treat the systemic stuff, don't miss the cardiac stuff and the pulmonary stuff. It will all help the wound. And don't forget about lymphedema of the legs, especially in these lower extremities. If you get the lymphedema treated, a lot of these wounds will do markedly better.
Okay, thank you. And Shelley.
Yeah, I just want to mention it looks like there's a lot of questions, so we will answer your questions, and in our follow-up email to you, we'll definitely send everyone the questions that were in the chat. So thank you very much. Really appreciate both of your expertise, and it was a great session. And thank you, Kathy, for hosting.
Yeah, and again, we appreciate all of you taking your time to learn more about improving wound care and wound healing, and welcome you to future webinars. So thank you so much, and look forward to seeing you all soon.